Students, today we will start with our next topic of cardiovascular system, that is the antiarrhythmic agents. It is nothing but the continuation of the last class. That is, we are going to study about the drugs, antiarrhythmic agents. Like you all know that in the last class we were discussing about the arrhythmias, very different types of cardiac arrhythmias, mechanisms of various mechanisms of arrhythmias, etc. So now today we will start discussing about the various antiarrhythmic agents. Okay. Now, what are antiarrhythmic agents? We know that antiarrhythmic agents are nothing but the drugs which are used to prevent or treat irregularities of the cardiac rhythm. Okay. So in the last class we discussed about the various criteria to be followed to declare any heart as a heart which is following a normal cardiac rhythm. And based on that, what are the various arrhythmias? Right. Now, coming to the agents, that the agents are the drugs which are used to treat cardiac arrhythmias. So these are the agents which will specifically correct or it will prevent the development of arrhythmias. Okay, so these drugs are classified basically into four divisions or four types. Okay, so they are the first one, that is the sodium channel blockers. Sodium channel blockers, or it is also called as class 1 blockers or class 1 agents, and it will come it is again it will be called as membrane depressant agents. Okay, sodium channel blockers or membrane depressant agents, that is class 1. And the next one is class 2. Class 2 is also called as beta receptor blockers, the one which we have discussed in our antihypertensive agents, same class. That also can be used as an antiarrhythmic agents. Then the third class is the potassium channel blockers. Class 3 is called as potassium channel blockers. And the class 4 is called as calcium channel blockers. That is the one which you already, again we have discussed it in detail about the calcium channel blockers. Okay, so these are the various classes of drugs used in the treatment of arrhythmias, cardiac arrhythmias. Okay, now what are these? See, before there are drugs, okay, any drugs that is used to treat arrhythmias can themselves cause arrhythmias. That is an important point to be noted here. Okay, so because if the drug is, it's going to uh, it will going to remove or prevent arrhythmias. Arrhythmias means it should cause an arrhythmia. Then only it can correct. Then only the correctness will be obtained. Okay, so that is why normally most of the cases the arrhythmias treatment will be given only when they are very much significant. Only when symptomatically it is required. Okay, symptomatically significant, very important, or when the benefit of the treatment clearly outweighs the risk involved. Okay. So when it is clear cut with this, then only the arrhythmia has to be treated with the antiarrhythmic agents. Okay. Now we'll see various classes of antiarrhythmic agents. That is the first one, class 1, that membrane depressant drugs. Okay. Or it is also called as sodium channel blockers. Membrane depressant drugs or sodium channel blockers. Okay. Now, class 1 antiarrhythmic agents are the drugs that have the membrane stabilizing properties. So, what is this membrane stabilizing properties? Means it's nothing but shift in the negative potential. Means shifting the membrane towards the negative potential. So, how you will shift the membrane towards a negative potential? More of a negativity you are bringing out. How you can bring a negativity means by blocking the positivity, right? So, by you're blocking the positiveness, so the negativeness is increased. That is what is happening. So what we are doing here is we are blocking the sodium channels. That is the positive channels of our drugs will act by binding to the sodium channels and thereby block the conductance until it is bound to those sodium channels. Okay, so now actually what by doing this, what happens is, as we all know, in the action potentials are initiated only when a cell is depolarized to the threshold potential. Okay, by an adjacent cell. So this is an action potential of one cell. So this is not an entire heart, it is a single cell. So like this, it is many is there, and after this also many will be there. Okay, in a single action potential, what are the changes taking place is what the representation of this figure. Okay, so any action potential are initiated when the cell's potential is increased to the threshold. So this is the threshold potential. Okay, this is the threshold potential. So when the sodium ions positivity slightly increases and it brings till here, that is above minus 80. Okay, so that is the threshold potential. Little above minus 80, that is a threshold potential. But when it reaches till there, okay, by an adjacent cell, means by an adjacent cell. After that, the previous cells are action potential when it drops and and it is in the threshold, below threshold. It comes below threshold, and then slowly it moves up near the threshold, and the next action potential starts. Okay, so like that it is there. So when it reaches up to the threshold, okay, so immediately what happens, there is a rapid opening of the sodium channels. There is a rapid opening of fast sodium channels, we call it as. So what happens is rapidly, means as the sodium ion flux takes place, sodium ion inflow of sodium ion is a positive charge. So I'm talking about the normal action potential. Okay, in the normal action potential, what happens when it reaches the threshold potential, when it reaches till here, then the sodium channels, we know various ions and their how they enter into the cell through their own channels, right? So like that, the sodium channels opens up. So there is a rapid influx of sodium. So what happens? The potential increases rapidly. So that is the phase zero. Very fast. It means the positivity inside the cell is increased. After that, there is a slow decrease. That is a negativity, little bit, very less potassium ion goes outside, so that the negativity is created, and then this is followed by the calcium ions, opening of the calcium channels. So when the calcium channels are open, again the calcium ions get inside, and that leads to uh, the contraction of the muscles or muscles. Okay, so that is the phase two, flow inward of calcium current. Okay, next is the repolarization. Repolarization means bringing the negativity to the channel in to the cell. Okay, so how that is taking place, how that is happening is, what happens here is, in as the calcium channel closes, okay, the potassium channels opens. Okay, the potassium channels opens. So when the potassium channel opens, what happens, the potassium outflows from the cell. Okay, outflows, it goes out of the cell. So positive ions goes out of the cell. So when the positive ions is going out, the negativity is created. So that is a repolarization. So negativity is the repolarization. After that, in the phase 4, the pacemaker, as usual, it comes to the phase 4, that is the threshold or the below threshold potential. Okay, these are the 4 phases of our action potential normally happening. Here one point is that between phase 1 to phase 3 is the refractory period. Okay, the time duration taken for this action potential or the and the this period. Okay, this period is called as a refractive period, and in during this period the it will not respond to any stimulus. So that is called as a refractive period. Refractory in nature means not responding to the stimulus. Okay, so this is normally happening. So how what our membrane stabilizing drugs does is it binds to the fast sodium channel. Okay, so means when it binds to the fast sodium channel, there is no influx of sodium ions. Sodium ions are not entering into the cell. There is no rapid current of sodium ions. Okay, so what happens when that is the case? The how the action potential will look is it will be something like this. So when the sodium channel is bound, okay, the negativity is more. Okay, so there is no immediate positivity, so it will go something like this. Okay, the negativity is more, and then the what is that phase plateau will be there. Okay, and then it goes, so it broadens. The one thing is the time duration taken is for one action potential is lengthened, it is increased, and also the refractory period between phase 1 and phase 2, that is also is increased. So by this we know that during the action potential or during the refractory period, the a cell will not respond to any stimuli. So by doing this, we can prevent the arrhythmias. Okay, so this is the mechanism of, this is how the mechanism of our uh, sodium channel, that is the membrane stabilizing drug, acts. That is by blocking the sodium channel. When sodium channel is blocked, there is no influx, sudden increase uh, of the sodium ions. So what happens? The sodium, the positivity is decreased. So the positivity is decreased means it is not like this. Slowly, it's like it takes like. So when there is more negativity, what happens? The duration of the action potential is increased, and also the refractory period is also increased. So thereby we can prevent the uh, arrhythmias. Okay, so this is about the this is what is our membrane represent agents perform their work. Okay, now this class 1 antiarrhythmic agents are again it is subdivided into three groups: 1A, 1B, 1C, based on the relative ease with which they dissociate from the sodium ion channel. Means based depending upon how easily it will come out of their binding capacity, it is divided into three types. Means how easily it can dissociate from the sodium channel, means for how long it is effectively binding with the sodium channel. Based on that, it is divided into three groups. Okay, so now drugs in this class, that is the drugs in class 1C, such as encanide, lorcanide, etc., are the most potent sodium channel blocking agents. They slowly dissociate from the sodium channel, so thereby causing the slowing of the conduction time of the impulses through the heart. That is class 1C. Whereas class 1B drugs, example lidocaine, tocanide, etc., they dissociate rapidly from the sodium channel. They does not stay, the binding is not for a long period of time, very short period of time. Since they are low potent, the potency is very less. Low potency, low potent sodium channel blockers. And whereas the class 1A drugs, that is quinidine, procainamide, disopiramide, have an intermediate between those two, a class 1B and class 1's intermediate rate of dissociation from the sodium channel. That is, they lengthen the refractive period of the cardiac tissue to cause the cessation of arrhythmias. Okay, so these are the different three types of the membrane depressant drugs. Now, it is what we say is that these drugs block the sodium channel. So as we all know that we have seen in the calcium channel also, any channel, ion channel exists in different states. They are not always be, it will be closed, or they are not always it will be opened also. Okay, so they'll be existing in three different states. Okay, that is here also sodium channel also will be existing in R, that is a rested state. At this state it is closed, but it can be opened by stimulation, or if there is a depolarization at that time it will open. That is a rested state. Then the another one state is there, that is the activated state, means allowing sodium ions to pass selectively through the membrane. That type of state is the activated state. And another one is inactivated state, it is completely unable to open. Okay, so our antiarrhythmic drugs, the more having is having more affinity towards the activated and the inactivated state only. Almost all the antiarrhythmic agents bound to the activated or the inactivated state of the sodium channel only, or both. Sometimes both the channels also it will be blocked. Okay, so this is about the mechanism of action of our membrane depressant drugs. So what are some of those? We'll see some of the membrane depressant drugs. So they are, the first one is the quinidine. So quinidine, we all know that quinidine is a dextrorotatory. Quinidine is a dextrorotatory diastereoisomer of quinine. Both quinine and quinidine are obtained from the species of cinchona plant. Quinidine is a prototypic antiarrhythmic drug that reduces the sodium ion current by binding to the sodium ion channel, thereby leading to the depression of the automaticity of the ectopic foci. So this quinidine is used to treat supraventricular and ventricular ectopic arrhythmias, atrial and ventricular tachycardia, atrial flutter, and atrial fibrillation. Quinidine is available in sulfate, gluconate, and polygalacturonate forms. So each possesses slightly different physical and the bioabsorption properties. Quinidine sulfate is an oral preparation that can be used intramuscularly also. It is rapidly absorbed from the GI tract, and the onset of the action begins within 30 minutes. Whereas quinidine gluconate is more soluble in water, and mostly it is used in emergencies when the rapid response has to be needed. And quinidine polygalacturonate gives more stable and even more uniform blood levels of quinidine. So that is about the quinidine. So the next drug of this class is the procainamide. Procainamide has emerged as a major antiarrhythmic drug in the treatment of cardiac arrhythmias. Why? Because procainamide is more stable in water, that is in the wide pH range of 2 to 7. Unlike quinidine, the advantage is that procainamide is bound to the serum albumin to significantly less extent. So the quinidine is more protein bound, and this is less protein bound, and at the same time it is also rapidly absorbed, 75 to 95% from the GI tract. So that is the procainamide. The next drug is the which is coming to about in this class is the phenytoin. 5,5-diphenyl 2,4-imidazolene diones. 5,5-diphenyl 2,4-imidazolene diones, or 5,5-diphenyl hydrotone. Okay, so it means that is nothing but it is a imidazolines. So it is 1, 2, 3, 4, 5, 5, 1, 5, 5,5-diphenyl imidazolene diones, 1, 2 diones. That is our phenytoin. Which has been traditionally used in the control of grand mal type of epileptic seizures. But in clinically, this phenytoin is used in the treatment of digitalis induced arrhythmias, and its action is similar to that of lidocaine. Then second class, that is about the first class of anti-arrhythmic agent. The second class is the beta adrenergic blocking agents. Nothing but the beta blockers, which we have studied in detail in the antihypertensive agents. That is, they are membrane stabilizing or the different depressant effect on the myocardial tissues. Mainly how? By inhibition of the adrenergic stimulation of the heart. That is on the SA node. Adrenergic stimulation of the by blocking the beta receptors, we get the antihypertensive properties. Okay, so example is already many drugs we have studied in the beta blockers of the antihypertensive agents. One more drug is there, that is tokenide hydrochloride. Okay, so this tokenide hydrochloride is an analog of again lidocaine only, and it is the difference is that it is even more better protected from the uh, first pass hepatic elimination after the oral administration. Usually, this tokenide hydrochloride is used to prevent or to treat ventricular ectopy and the tachycardia. So that is the beta adrenergic blocking agents. Then coming to the next one, that is the third class, class 3 of three of the antiarrhythmic agents, that is repolarization prolongators or potassium channel blockers. Okay, repolarization prolongators or potassium channel blockers. So same here also, as we all know, same like sodium channel blockers. In this case, that these drugs blocks the potassium channel. So when the potassium channels are blocked, the action potential will look something like this. That is the red one. The black color is the actual action, normal action potential. So when the potassium channels are blocked, okay, so there what happens? There is a very slow, very slow outflow of potassium channels. So what happens when the potassium channel not um, for moving fast? It is moving, okay, out, but it is not moving fast. So what happens? The action potential is not completing fast. It's taking long time. So, so when it is taking long time, instead of finishing within this time, it is taking even more long time. Okay, long time it is taking to finish an action potential. So it is the cardiac cells remain refractory. The refractory period is also increased. So thereby, we all know that increase in the effective refractory period will suppress the cardiac arrhythmias, mainly by re-entry mechanism. Cardiac arrhythmias caused by re-entry mechanism can be suppressed by using potassium channel blockers. That is what this paragraph says. Right. Now, coming to the drugs. The drug is the amiodarone. Amiodarone is nothing but 2-butyl, 2-butyl, this one, 2-butyl, 3 benzofuranil, 1, 2, 3 benzofuranil, okay, 4, this 4, okay, 4, 2 diethyl amino, 1, 2, this is diethyl amino, ethoxy, this is ethoxy, 3, 5, 3, 5, okay, 1, 2, 3, 4, 5, so 3, 5 diiodophenyl ketone is called as amiodarone. Amiodarone was introduced basically as an anti-anginal agent, but later on it was found to have pronounced antiarrhythmic action. Amiodarone lengthens the effective refractory period because it is a potassium channel blocker, and the drug has a very slow onset of action, that is days, and also elimination also is very slow from the body, that is with a half life of approximately a month following the oral doses. Okay, again, this drug is having some disadvantages. Okay, that is, the main is that this drug is having an iodine atom in its structure. Okay, so hence it affects the thyroid hormones. So around 11% of the patient are found to have hypothyroidism on this treatment. Okay, hypothyroidism occurs in up to 11% of the patients. Okay, and in addition to that, it also inhibits the enzymes of oxidative systems, thereby interfering in the normal metabolism of other drugs. Okay, so this is about the amiodarone. Then the next drug is there, that is bretylium tosylate. Bretylium tosylate is nothing but the orthobromobenzyl, this is orthobromobenzyl ethyl dimethylamino dimethyl 1,2 dimethyl ammonium dimethylammonium paratoluene paratoluene sulfonate. Okay, so this drug is a quaternary ammonium salt that is extremely soluble in both water and alcohol. And bretylium tosylate is an adrenergic neuron blocking agent that accumulates in the neurons and displaces norepinephrine. And because of this, it was earlier used as an antihypertensive agent, but its use was discontinued due to the development of tolerance and some other pain-related side effects. So it is not much used as an antihypertensive agent, but comparatively it is preferred as a anti-arrhythmic agents. Okay, so this is about the potassium channel blockers. So the next one is the next class of our these anti-arrhythmic agents was calcium channel blockers, right? Sodium channel blockers we discussed. Then beta adrenergic blockers, it comes under antihypertensive agents. In detail, we have already discussed. Okay, and potassium channel blockers we just now we discussed, and where you have to study amiodarone and bretylium tosylate. And the class 4 drug is the calcium channel blockers. So calcium channel blockers also we have already discussed in the previous classes. So the same content you can refer for this chapter also. Okay, so this is about the anti-arrhythmic agents.